Now I am going to treat the so-called soft tissue approach to implant installation or mucogingival approach to implant installation, which is an approach that obviously gives much more importance to the soft tissue management and the aesthetic outcome than to the buccal bone. And the reason why I really believe in this soft tissue approach, it is because we were so successful in treating gingival defect lesions around implants, as I show you, with a mucogingival procedure, mainly together with the restorative approach. And this coverage of very, very bad implant position, of implant with no buccal bone due to the bad implant positioning, after 5 and now 7 years, it's very, very stable. Or if there is a change, there is a further increase in the coverage with respect to the 1-year outcome. So what I thought from this very, very successful outcome is, if the implant is placed bad, if there is buccal bone loss because of the bad implant installation, if you are able to keep this implant perfectly covered and stable after 7 years, most probably the importance of the buccal bone was overestimated with respect to the risk of gingival recession to form, and the importance of the soft tissue was underestimated. So the idea is, I make implant installation, and together with implant installation, I augment soft tissue thickness so that I create a transmucosal zone where the soft tissue is thicker than 2 millimeters. So the gingival recession at the level of the soft tissue margin is protected by the increase in the soft tissue thickness. And then, even if there is some minor amount of buccal bone, I don't care so much, because this will be compensated by connective tissue graft, since in my case, I also place the implant correctly in the right position, because I guide as much as possible implant positioning in relation to the final restoration in order to give our patient a screw-retained implant-supported crown. So this is the idea, not to give so much importance to the need of having really 2 millimeters of bone thickness at the buccal aspect of our implant. And we did this soft tissue approach in 2 different clinical scenarios. One, it's the delay. So we extract the tooth, we don't do anything for 6 months, and then we place an implant. And at the time of the implant placement, we make the immediate temporization plus the connective tissue graft. Or the second, we make immediate implant installation with immediate temporization and simultaneous soft tissue augmentation. I don't see the need to do anything in the middle, because if I cannot make immediate implant installation, it is because most probably there is not good bone enough at the time of tooth extraction in order to give my implant primary stability enough to apply the temporary crown immediately. And if there is no primary stability enough at the time of tooth extraction, there is no primary stability also in 3 weeks' time. Because there is somebody in the literature suggesting that the best time is early implant placement, 6 weeks, 8 weeks after tooth extraction, but in 6, 8 weeks, maybe the soft tissue heals, in my opinion, not completely, but for sure, nothing changed at the level of the bone. And so If you don't have primary stability at the time of tooth extraction, you don't have primary stability also in 6 weeks. So this is not a choice I consider. And so in the case of tooth extraction, for dental reason, because periodontal reason is another story that we will treat separately, we have 2 options. One is immediate, the best for our patient. You remove the tooth and you place the implant with the crown immediately. Or if you cannot, because there is the complete loss of the buccal bone, there is the complete loss of the palatal bone, we have to wait. And we have to wait the time it takes also for the bone to remineralize and to give the best choice for the primary stability, which is necessary for the immediate temporization. So in the delayed approach, we remove the tooth, we apply a Maryland bridge, we wait 6 months, and obviously, since it's a tooth that was extracted for dental reason, it's a buccal fracture, we have a concavity due to the buccal bone loss, due to the loss of the bundle bone and the root. But since the bone peaks, because it's not periodontal disease, was good, the amount of apicocornal soft tissue and hard tissue loss is very limited. We have good preservation of the papilla height. There is no defect in apicocornal dimension, but only or mainly in the buccal lingual dimension, even if this defect is quite big. What about the bone? In 6 months, the bone comes back perfectly with no need of any socket preservation, with no need of any bone augmentation, because the bone peaks is perfect, the palatal bone was perfectly maintained, and the buccal bone will be restored spontaneously. And obviously, when we guide our implant installation, we want to leave bone enough, buccally and palatally. But between the two, I always prefer to leave enough bone palatally, and even if the bone at the buccal aspect is not as it should theoretically, 2 millimeters, I don't care so much, because I don't think that we really need 2 millimeters of bone thickness for the implant. 2 millimeters of bone thickness is something you need, most probably, if you don't make any soft tissue augmentation procedure at the time of tooth installation, but personally, I don't believe it's really something that you should do. If you look at the planification of the implant installation, we want that the medium axis, the axis passing through the mid portion of the implant, is not getting out at the level of the palatal cingulum. This is too much palatal. And when you place the main axis of the implant at the level of the palatal cingulum, the profile, the emergence profile of your implant becomes too much horizontal. I don't like it so much. We prefer to have the main axis of the implant getting out at the level of the palatal aspect of the incisal edge, of the cuspid. So this is where we plan our implant installation in the buccal lingual dimension. So with minor angulated tools, we can make a screw-retained crown, but at the same time, we don't place the implant too much palatally. That makes this emergence profile too much horizontal. This is the planification in the buccal lingual dimension. While in the apicocornal dimension, the planification of implant installation is related to the aesthetic parameters. And as you know, the aesthetic parameters are guided by the position of the soft tissue margin of the homologous natural tooth that, in the case of very, very healthy tooth, is located about 1 millimeter more corner than the soft tissue, than the cement enamel junction. So this red dot line is our reference for the apical corner positioning of our implant. So we want to have this red dot line, same level, opposite tilt horizontally at the level of the dentulous area. And then we want to decide how much go apically in order to place the surface of the implant that can be integrated into the bone. Because I'm not saying the head of the implant, because the head of the implant depends on which implant are you using, because if it's transmucosal implant, the head of the implant is the head of the transmucosal zone. while if it's a bone level implant, the head of the implant is the area where osseointegration starts. I'm speaking where to place the implant that can be integrated, the buccal surface of the implant that can be integrated into the bone. So where the rough implant surface, which is used to be integrated to the bone, should be placed. And we decide to place it at 3.5 millimeter distance from the soft tissue margin. That I think is a very, very good compromise. 4 millimeters is good. More than 4 is too much apically. 3 is great risk, because 3 millimeters is very, very corner, too much corner to give right emergence profile to the crown and also to find enough bone. As much as you go coronal, in order to have bone, you have to go palatally. And this is something that we don't like for the maintenance and for the soft tissue management. So the better compromise we decided is 3.5 millimeters apical with respect to the ideal position of the soft tissue margin, and buccal lingually, the axis of the implant coincide with the palatal aspect of the incisal edge or cuspid of the tooth. After the last drills that was used, this is the last time when I can measure the thickness of the bone remaining at the buccal aspect before implant installation. And when I measure this thickness, this is 0.5. So theoretically, not enough, because according to the literature, this thickness should be 2 millimeters. But yes, theoretically it's not enough, but it's not true that it's not enough to place an implant, because guiding my implant as much as possible and be precise and atraumatic, I can place my implant without creating any implant exposure. So there is no thread exposure at the time of the implant placement. So for sure, this bone is not thick enough theoretically, but it's enough to place an implant because I don't create any dehiscence at the time of implant installation. So now what's the problem is that if you consider that this bone is so thin, and if you consider that theoretically there will be some bone resorption, which is related to the trauma of implant installation, some of the bone that now is perfectly covering the implant thread could be resorbed and eventually could make implant surface exposure. So now we are in a situation that is very, very frequent when you extract the tooth for dental reason, and it is the situation in which you don't have so much buccal bone because some bone was resorbed, but still there is enough bone to place an implant. And what can happen in this case is that maybe 1 millimeter, I don't know, 1.2, 0.8, 1.5 millimeters of implant could become exposed if really this bone that is present at the time of the surgery is going to resorb. So now the question is, what do you apply here? On this area where you still have a thin layer of bone that could be resorbed, and so you could have metallic exposure during the healing if this area really resorbed. Which is the best material to be applied on this very, very thin amount of bone or on this very, very shallow amount of metallic exposure? Do you really think that the bone of the patient is the best material? Do you really think the xenograph is a good material? My question is, what's the possibility that bone of the patient, xenograph or whatever it is, can integrate to the implant surface when the exposure is really so small? We are speaking about most probably 1 millimeter, I don't know, maybe only 1 millimeter of metallic. And what is the predictability of GBR procedure when the dehiscence is 1 millimeter? We don't really have so much data. What we know that GBR is very predictable. And so if you have a bone dehiscence of 10, maybe 1 millimeter is the remaining dehiscence and the 9 are covered, but 1 millimeter is remaining. But the problem is when the dehiscence is only 1, What is the predictability of GBR to cover the issues of 1 millimeter? First question. Second question, what happens if there is a bone dehiscence of 1 millimeter? We know that there is a lot of implants that have dehiscence unexpected. You make a cone beam for other sites, and when you go to the frontal side where you place the implant and where there was bone at the time of the implant placement, maybe there is no any intact bone anymore, and there is a shallow dehiscence, but the implant is perfect. No recession, no mucositis, no perimplantitis, nothing. Most of the dehiscence are completely unexpected. So most probably the presence of a shallow dehiscence is not such a problem for the implant. And the only problem that the literature tells you in the case of dehiscence is the risk of recession. But since you are a periodontist and you know that the recession don't start at the level of the bone, but start at the level of the soft tissue margin, we decide to take care of the risk of gingival recession to start at the level of the soft tissue margin by making a soft tissue graft. Because yes, even if the bone don't resorb, there is still an area where I have to make something to prevent gingival recession to form, and this is the area which is comprised between the soft tissue margin of the implant-supported crown to the buccal bone, that even in the best situation where the bone don't resorb, it's 3.5 millimeters. And in this 3.5 millimeters, is the thickness of the tissue more than 2 millimeters? No. So in order to give the right thickness of the tissue here, in order to mask the transparency, to prevent the risk of gingival recession to form, I know that I have to graft, connective tissue graft, this 3.5 millimeters area in order to prevent the risk of gingival recession to form because of the fact that here the soft tissue is not attached to the underlying surface as these tissue are attached at the level of the adjacent teeth above the suprabony component of the root. So in this approach, we want to apply in the 3.5 millimeters area a connective tissue graft. But we also know that since the bone that we are leaving apical is very, very thin, we want to extend our connective tissue graft to the area where the bone is very, very thin. So we extend 2-3 millimeters the connective tissue graft above the very, very thin bone. And we also place the connective tissue graft as rule of thumb, a bit more coronal, 1 millimeter more coronal than the ideal position of the soft tissue margin, because we want to compensate the risk of shrinkage, and we also want to give our restorative dentist tissue thickness in excess for the conditioning phase, which means better aesthetic outcome. So this is the connective tissue graft we need. No need for bone augmentation, but we protect the area where the bone is thin by extending the connective tissue graft to this area for a couple of millimeters. But what's the great advantage of the delayed implant installation? That, as you can see, we make a very, very small punch only in the middle of the dentulous area, and this small punch is of the same diameter of the implant site, so 3.7, okay, 3.8. So if we make a punch only in the middle, it means that what we leave mesial and distal to the implant site, it's very, very large, very, very dense, very, very mature papilla that is, I think, very, very similar or much, much better because they comes from 6 months of maturation after tooth extraction with respect to those papilla that I try to improve by removing the crown, changing the abutment, and making it as narrow as possible when I was treating the lesions around the implants. So this is wonderful papilla, very, very large, no triangular trapezoidal tip, whose desepitalization can eventually be extended also to the palatal aspect, and it's extremely, extremely mature, because they comes from a healing of a tooth that was extracted 6 months before. So to this papilla, I have the opportunity to fix my connective tissue graft at the base, but also to use this papilla for the healing of the surgical papilla of a coronally advanced flap that must be adapted to a temporary crown that can be applied at the time of the implant installation, because no doubt that I have primary stability enough because the bone is completely healed. And this temporary crown is made of a convex surface that starts 1 millimeter more coronal than the position of the soft tissue margin of the adjacent tooth, because where the convexity of the temporary crown starts is where I have to apply my connective tissue graft. And this can be scheduled before the surgical procedure, because since the implant is guided, I ask my technicians, please prepare a temporary crown whose convex surface, who has the same outline of the enamel of the adjacent tooth, starts about 1 millimeter more coronal than the previous position of the soft tissue margin of the adjacent tooth, because I know this is exactly where I have to place my connective tissue graft. 1 millimeter more coronal than the soft tissue margin. And then the temporary crown is rebased to the implant site, leaving the temporary crown slightly concave in the area, which provides a very, very good surface for the stabilization of the connective tissue graft, which is also extended a couple of millimeters at the level of the bone, where the bone is thin. So we prepare everything before implant installation. The temporary crown has a convex surface that starts 1 millimeter more coronal with respect to the soft tissue margin of the adjacent tooth, and then a slightly concave area that will be rebased intrasurgically to the implant head. And everything is fitting quite precisely because the implant is guided, and so the temporary crown is already quite precise. The convex surface of the temporary crown is the surface that you will use to adapt the keratinized tissue of your flap that will be advanced more to cover completely the connective tissue graft and to make first intention wound healing between surgical and anatomical papilla. So this is mucogingival approach to implant installation, because this type of approach is identical, the type of flap we open at the buccal aspect, identical to the type of flap we use for treating gingival recession. What does it mean? We use the adjacent papilla, split thickness, with oblique incision that are always directed this time to the tooth, that is to the implant site. So different from the only difference with respect to the treatment we did this morning, that was multiple treatment of gingival recession. This morning, all incision was directed towards the canal. Now, the only difference is that the all incision are directed towards the edentulous area. How many papilla you open laterally to the edentulous area depends how much you want to advance the flap. The more you want to advance the flap, the more is the number of papilla that you have to open mesial and distal in order to have a bigger flap that can be advanced easy. The less is the amount of advancement of the flap, the more you can reduce the number of papilla that you include in your flap design. Once the advancement of the flap, it's not so big because there is no so much apicocoronal soft tissue loss, we just open one mesial papilla, one distal papilla with respect to the implant site split thickness. Also, the implant site is a very, very big split thickness papilla. I want you to understand that the whole tissue that we are elevating at the level of the implant site is elevated like the mesial and distal split thickness papilla, keeping the blade parallel to the external surface, parallel to the external surface. So what I'm elevating, it's only a buccal flap that is so thin, whose thickness corresponds to that one of the papilla. So it means that only the buccal flap, only the buccal tissue is elevated, but the whole tissue, palatal, crestal, is left untouched. You understand? It's only a buccal flap, elevated split thickness, like the flap we use for treating gingival recession. So no crestal incision, no palatal incision, no mid-crestal incision. No, 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 no. Only buccal. And from this buccal tissue, we only remove a epithelium and connective tissue layer. So that's why this one of the dentulus site should be considered a very, very large split thickness papilla, okay? Once the bone is reached, once the buccal bone is reached, like we did just now, we overcome the bone, full thickness, so same in the dentulus area. Once the buccal bone is reached with the blade, we overcome the buccal bone with the periosteum elevator. And why we overcome the buccal bone with the periosteum elevator? Because if we want to make split thickness elevation where there is the over-counter of the bone, you risk to perforate or to thin the buccal flap too much. And you don't want to thin too much the flap where the flap is covering the buccal bone. So once with the blade you touch the buccal bone, you cannot try to be split thickness because it's very difficult to overcome the bone with the blade, but it's much easier to overcome the bone with the periosteum elevator, and once the bone is overcome, you go back, split. And which split you make? It's again two different split thickness. One is called deep, but we know everything about this because it's the same incision that we make when we make the flap advancement. And then superficial. The superficial incision will be extended more mesial, more distal, like in the treatment of multiple gingival recession, to allow the flap in the middle to advance more coronally with respect to the previous position. What do this flap do? Also increase or is advanced at the level of the adjacent teeth. So if the adjacent teeth has gingival recession, you can also treat the adjacent teeth with gingival recession. If the adjacent teeth has whatever type of disalignment, you can treat also this disalignment in one surgical procedure, and eventually you can also add connective tissue graft if some of these teeth don't have any remaining or enough keratinized tissue, because this flap is identical to the flap we use for treating of multiple gingival recession. Now, it's very important to be very precise in implant installation where we schedule our implant installation, and we don't want to touch nothing on what is the mesial and distal papilla to the implant site during the drillings, during the perforation. So in order to be precise in making the area where we are going to place an implant, I use my surgical stand. I use a mini blade which is kept in contact to the walls of the first drill, so I can sign exactly with my blade the area that will be punched by a full thickness incision to the level of the crestal bone, and only the soft tissue, the minimal amount of soft tissue that is covering the crestal bone where there will be the perforation by the drills is site-specific remove full thickness. This means that when you are going to use your drills and your implant installation, you don't touch the mesial and distal papilla, because the full thickness exposure of the crest for implant installation is site-specific, guided by the surgical stand. So this is a flap that makes a very, very big, wide mesial and distal papilla that are connected with no interruption to the or palatal soft tissue that was never elevated. Now we can use our surgical stand to perforate, to prepare the surgical site, and to place our implant. And once the bone is completely healed, we can also place our implant by hand. It should not be fully guided because the risk of bad implant positioning in a healed bone is very, very reduced. But this is a way to be very, very atraumatic for the papilla area that is left untouched, and also for the adjacent soft tissue. And the only thing that we remove from the dentulous side, it's a split thickness, very, very large papilla. And this is the most important pictures that tells you that with respect to the area where we prepare the site, mesial, distally, and palatally, everything is left completely untouched, and only some minor amount of tissue, which correspond to epithelium and minimum amount of connective tissue of the split thickness papilla, is separated at the buccal flap in order to be advanced, more coronal. Then it's time now to make the desepithelialization of the mesial and distal papilla, and also the desepithelialization of the adjacent papilla of the dentulous side in order to guarantee the advancement of the flap by anchoring the surgical above the anatomic desepithelialized papilla, like we did this morning for the treatment of multiple gingival recession. So now everything is ready for rebasement of the temporary crown, and this temporary crown is already very precise because it was prepared on the same impression that was used to prepare the surgical guide, and with respect to the ideal position of the enamel, that is the same of the enamel of the adjacent tooth, it is rebased intrasurgically, creating a very, very slow, progressive, concave surface from the convexity of the enamel to the implant site. And being this temporary crown already very precise, it takes very, very few time to be rebased intrasurgically. What is very important is that your technicians or your restorative dentist reduce as much as possible, make it almost concave, the area where the temporary crown is in contact to the mesial and distal papilla. That is very important because the temporary crown is a very important support for the connective tissue graft, 1 millimeter more coronal to the previous position of the soft tissue margin of the adjacent tooth, but also for the papilla, but it should not disturb by compressing the area where the surgical papilla of the flap should close by first intention with the anatomic desepithelialized papilla, mesial and distal, to the temporary crown. Now that the graft is placed, we only have to advance the flap. You see that the amount of connective tissue graft we take is no more than 1.2, 1.5 millimeters, even in very, very big defect, because it's not only the connective tissue graft that is working to compensate the defect, but is the combination between the temporary crown, which also keep the connective tissue graft more buccally, and the coronally advanced flap that must completely cover forever the connective tissue graft. So we have three different layers of tissue: temporary crown, connective tissue graft, and coronally advanced flap that will compensate for treating the defect. Now the flap is advanced, it's stabilized in the coronal position, and the same sling suture that we saw around the palatal aspect of the adjacent teeth is also used around the palatal aspect of the temporary crown in order to make very, very first intention wound healing between surgical and anatomical papilla. So in other terms, the temporary crown is used exactly in the same way of the enamel of the adjacent teeth, like a tooth that is treated by gingival recession together with the adjacent teeth. It's very important that the soft tissue margin, it's very tightly adapt thanks to the sling suture to the convexity of the enamel, not to avoid any blood seeping from the soft tissue margin. This is a very important concept of surgical stability that reduce the risk of soft tissue shrinkage. So the temporary crown is critical in order to advance the flap, to sustain the flap in the buccal position, because it's the same buccal position of the adjacent tooth, but also to completely cover the connective tissue graft that is placed 1 millimeter more coronal than the previous position of the soft tissue margin. So now you see the healing. This is 1 month. And please take a look of the profile, because as much as the maturation goes, you will see that there is an increase in the soft tissue thickness because of the combination between the coronally advanced flap and the connective tissue graft. In this case, since the patient has the temporary crown fixed, we can wait 6 months, not 4 months only, but also 6 months for having the complete maturation phase. And the only thing that you do in these 6 months is to unscrew the crown sometimes. And if you see that the papilla needs more space because the graft was also extended, yes or no, to include the more mesial and more distal papilla. So this papilla that is thicker than before has the tendency to grow corner. And if the tendency of this papilla to fill the space, you have to open the space a bit more by reducing again the temporary crown and shifting the contact point more corner and leaving more space for this papilla to grow in corner direction. But in 6 months' time, the whole defect, which is comprised between the ideal position of the enamel to the previous pre-surgical position of the soft tissue, is only compensated by 1 millimeter 0.2 of connective tissue graft plus the corneal advanced flap plus the temporary crown. So this is at 6 months. At 6 months, what we need is to reapicalize the soft tissue margin, so to make it exactly of the same height and of the same shape of the homologous natural tooth. This is called conditioning phase. And this conditioning phase must be performed not simply by adding material to the temporary crown and compressing, because this material, this tissue, it's so thick, it's so dense, that if you try to apicalize only by screwing the temporary crown with some more composite flow in the top, you risk to create too much ischemia to the tissue and also to bring the papilla height. So in order to condition this tissue that is so dense, so mature, 6 months after the surgery, you have to wear it. So some of this tissue must be weared by using a diamond burr, and the space that is weared with a diamond bar will be occupied by adding composite flow to the temporary crown. So 90% of the conditioning is done by wearing the inner aspect of the pontic, and 10% by compression, which is done when you screw back your temporary crown. The ischemia due to the compression must only be buccal with no compression at the level of the papilla. Otherwise, there is the risk to displace them apically. And this ischemia should last only a few minutes. So this is the area where we make the conditioning phase that you see it's not buccal, because if you extend your wearing to the buccal surface, you also risk to expose the graft, and this is something that you never want, but only to the area that was grafted. And you see that where you make our conditioning with the diamond burr is exactly where there was the defect before. So this is really new connective tissue formation, which form and mature for 6 months. So this is the same day. This is before conditioning. This is at the end of the conditioning phase by wearing the inner aspect of the pontic and adding some composite flow to the temporary crown. And this is repeated sometimes to realign the soft tissue margin and to promote the maximum growth of the papilla, which is done also by squeezing a bit this papilla in lateral direction. Once the soft tissue margin is in the ideal position and the distal papilla of the implant side is at the same level of the papilla of the natural tooth, this is the time for the final restoration, that in this case obviously can be screw retained, because I guide implant installation so to have a screw retained implant supported crown. And this is the soft tissue before implant installation and soft tissue segmentation, and this is the soft tissue at the end of the conditioning phase. And you can see that all the defect has been compensated with no need of any bone augmentation. But if you consider that the defect is mainly in the corner aspect, so in the area where at the level of the adjacent tooth there is the root with no bone, it was quite clear even from the beginning that this defect should have been compensated by soft tissue segmentation and not by bone augmentation, even if I don't want you forget that in this implant, I left very, very thin bone, yes, that I don't know what is going to happen to this bone. Final restoration, 1 year after final restoration, very, very similar profile and shape of the implant-supported crown and the adjacent tooth. And also, the emergence profile of the implant-supported crown is very, very similar to that of the adjacent tooth, where we have a convex surface that is more or less the area that was connective tissue grafted. And then, as much as we go apically, where the buccal bone starts, like in the natural tooth, the soft tissue goes very, very palatally and not very, very buccally. So we were able to give really to reach a situation that is very, very similar to that of the adjacent homologous tooth. This is the 5 years outcome. And if you look carefully here, when you pull the lip, there is an area here where you can see some whitish tissue. And this is because this is an area belonging to the alveolar mucosa, but when you pull the lip, the alveolar mucosa becomes a bit ischemic because below there is a greater thickness of tissue. I hope that you remember that in this case, the bone was very, very thin. And in the area where the bone was very, very thin, I extended my connective tissue graft for a couple of millimeters. And this is exactly this area, 3.5 millimeters area, only soft tissue, and then 2-3 millimeters more at the level of the bone. The connective tissue graft was extended because the bone was thin. Now the question is, do you think that here we have bone lesions? And the second question is, who cares if there is a 1.2 millimeters of bone lesion there? Because, you know, if you look at the radiograph, and if you compare the radiograph of 1 year after loading and 5 years after loading, you see that there is a great stability of the bone. But if you look very, very carefully, you also see that even at 1 year after loading, there was a minor amount of bone resorption. The bone should be at the level of this is a bone level implant, so the bone theoretically should be at the level of the implant head. While if you look at carefully, the bone resorbed a bit, let's say 1 millimeter with respect to the ideal position. And this is obvious because if you use a bone level implant, if you unscrew the crown, also one time for conditioning the soft tissue, the only area where the biological width, which means connective tissue adhesion, can form is thanks to bone resorption. So the bone here most probably resorbed, not because a problem of the bone, but in order to give the 1.2 millimeters of connective tissue adhesion, which forms coron to the bone crest. So what I can tell you is that this 1 millimeter, 1.2 millimeters here of bone loss is not pathological, but is connective tissue adhesion. And it's so strange that this connective tissue adhesion is not so strange. It's so normal that this area is perfectly stable 5 years later. It's perfectly stable 7 years later. So this is the true demonstration that it's not bone loss, but it's simply a biological phenomenon due to the biological width formation around the implant. But what is strange is that you accept this connective tissue adhesion here, which is interproximal and infrabony, and you don't accept eventually if here there is some connective tissue adhesion because I left the bone very, very thin and I applied the connective tissue graft above it, and if the bone really resorbs, I will have 1 millimeter, 1.2 millimeters of connective tissue adhesion instead of bone. So what is the most risky for, let's say, perimplantitis? The connective tissue adhesion interproximal, infrabony, or the connective tissue adhesion buccally and suprabony? Obviously, buccally and suprabony, the patient can clean perfectly, much more easy than interproximal and infrabony. So I'm really wondering why people with implant therapy, they are so worried to leave, let's say, 1 millimeter of connective tissue adhesion at the buccal aspect And if the bone is thin, they increase the bone because they don't accept to have 1 millimeter of connective disadhesion, but they are not worried about the connective disadhesion that eventually can form interproximally and infrabony if you use a bone level implant with a bone or implant abutment connection at the level of the bone. So if you really don't want to have any risk of remodeling phase of the bone, I would suggest that you use other type of implant, which is tissue level or one abutment one time, where the biological width will form on the suprabony component and not thanks to bone resorption. So this is the 5 years outcome. We see that where the bundle bone and the root is completely compensated by the soft tissue augmentation procedure. And if you look 7 years after, if there is a small change, is the area where theoretically we don't have bone and we have only connective tissue, is even thicker after 7 years with respect to the 1 and to the 5 years. So I'm not worried at all if in that area where I left very, very thin bone, if there is adhesions or not. But these pictures most probably tells me that where the connective tissue graft is placed on the bone, there is something that promotes further growth of tissue, and we don't know for sure if this further growth of tissue is really only soft tissue, but it's also hard tissue. But this is not my problem. My problem, this is not the patient problem, and there is no problem at all. So I think that with a good soft tissue augmentation procedure during implant installation and with immediate temporization, we can for sure compensate for minor amount of bone loss once the bone adhesions that will form at the buccal aspect is less than 3 millimeters with no risk at all of any recession or any problem at the level of the implant site. Let me just show you another case, which is very, very similar to the case of the treatment of multiple gingival recession with implant installation. We have an area where there is a concavity because the tooth was extracted because of the buccal fracture, so we have lost some of the buccal bone. And in this area, we also have some very, very flat outline of the dentulus area. So if I want to give a nice premolar to this patient, the only thing in order to resemble for this premolar to have papilla, since I have a defect buccal lingually that is much better evident when you see the profile of this patient. So compared to the position of the soft tissue of the adjacent tooth, there is a buccal lingual defect. The only thing is to make a premolar longer than the adjacent premolar, which does not have a very good emergence profile because here there is no thickness enough for the tissue. So I don't think this is a good choice for our patient. This is not a good choice because the premolar theoretically should be at the same level of the soft tissue margin of the adjacent premolar. But in this position, we don't have tissue. So can we gain in one surgical procedure not only more coverage, so reduce the implant-supported crown, but also promote papilla growth with time? Yes, we can if we remember to extend the connective tissue graft to the base of the papilla at the time of the surgical procedure. We guide our implant. We know that there is a minor bone adhesion in the most corneal aspect, but we don't care because these adhesions will be compensated by extending the connective tissue graft instead of making bone augmentation that in a case like this is really not necessary because there is the right height and thickness of bone. Flap design. We are treating a posterior segment. The all incisions are directed towards the dental site. And since there is also papilla, since there is also recession in the adjacent teeth, we extend much more our flap with respect to the previous case because I also want to treat the recession of the central, of the lateral, of the second premolar. And what about how I elevate the soft tissue at the level of the dentulous area, like a very, very large split thickness papilla, keeping always the blade parallel to the external surface and leaving the whole tissue completely untouched. So this is exactly the same flap we use for treating multiple gingival recession, that in this case is even easier to understand because there is also gingival recession in the adjacent teeth. So keep the blade parallel until you reach the buccal bone, and be careful, overcome the buccal bone full thickness, not to risk to thin too much the tissue in the area where the soft tissue attached to the buccal bone. So this is the very limited area of full thickness elevation of the flap. You see that there is a minor bony defect in this area, that it's so small that I prefer to compensate only with soft tissue grafting with no need of hard tissue grafting, because don't forget, or you use only bone of the patient, but this is not a good osteoconductive material, so it's not very stable. But if you use bone filler, and if you apply bone filler in the area where the bone filler do not transform or do not integrate into the bone particles remains in the soft tissue, will be encapsulated in the soft tissue, and this could be a reason for failing, because in the case of contamination, they become really very, very easily contaminated. This is the flap that you know, buccal flap, used for treating gingival recession, which also create at the level of the dentulous area the possibility to be advanced more coronal and to be applied on the convexity of the temporal crown. Now I punch only in the middle, and this punch, not to alter the mesial and distal papilla, is guided by the surgical stand. So I remove full thickness of the tissue only in this area. And during the perforation, you see this tissue, papilla, mesial and distal. There is also a very, very small soft tissue bridge here that is left untouched during implant installation, just to tell you how much atraumatic is your surgical procedure. So you theoretically can leave a bridge of tissue that obviously you lose because you need to make the rebasement, intra-surgical rebasement of the temporal crown, which is already very, very precise because the implant was guided. And so the technicians prepare the temporal crown fitting to the implant head, very, very precise. And now you have to reduce mesial distal in order to avoid any excess of contact to the papilla, and you have to reduce buccally. That is the right place for the application of the connective tissue graft. But now, during the time it takes for the rebasement of the temporal crown, I can make the desepithelialization of this papilla that, yes, is very flat, but it's very large. And so I can desepithelize them towards the palatal aspect, and this is the key. I apply my connective tissue graft not only where there is the implant side, but also to include the whole mesial and distal papilla, because by increasing the thickness of this papilla, I want also to promote papilla growth in apical-coronal direction. The temporal crown is ready, but it's better to suture the graft with no temporal crown, because it's easier to make the full thickness perforation of the papilla, as we have already saw, full thickness perforation from the palatal aspect and close, because we don't want the graft overlap the area of the papilla, but we want that the graft is blocked at the base of the papilla, leaving the mesial and distal papilla desepithelialized, completely free for the surgical papilla of the coronally advanced flap. So the graft is perfectly positioned, and once we will screw our temporal crown, the mid portion of the connective tissue graft will be placed more buccally, and this is very good in order to give even more emergence profile, even more thickness to the tissue. So this is the connective tissue graft application, which also extend to the area of lack of buccal bone. Now I screw the temporal crown that was reduced interproximally, not to touch the papilla at all, and this is the time for advancing the flap, which will be also advanced and adapt at the level of the implant site to the temporal crown, like the keratinized tissue is adapted to the enamel or composite restoration that were done in order to restore some abrasion defect. at the level of the adjacent teeth. So in other terms, in one surgical procedure, we treat all gingival recession, we apply the implant, we increase the buccal aspect of the tissue, we increase the apicocorno dimension of the tissue by advancing the flap, and now we know, and that's absolutely incredible, that we can also promote papilla growth, because this papilla that will be increased in the buccal lingual dimension by extending the connective tissue graft to this area has also the capability to grow in apicocorno direction. So we adapt our flap to the temporary crown, like to the enamel of the adjacent teeth with the sling suture. So this is the end of the surgical procedure, like it is for treating of multiple gingival recession. 15 days, you can see how much not only the tissue is growing buccally, but look the buccal lingual dimension of the distal and mesial papilla because of the extension of the connective tissue graft to this area. This is the key. How can you apply the connective tissue graft here? You have to elevate the flap. Can you apply the connective tissue graft to this procedure with the tunnel procedure? Can you do it flapless? So I mean, maybe flapless is a good choice if you're not able to elevate split thickness papilla. That's the only conclusion I can give you. So if you're not able to elevate the split thickness papilla, maybe it's better to do flapless, because if you make a wrong elevation of the papilla, you can create damage. But if you know what is a split thickness papilla, it means that this is only epithelium and connective tissue that is elevated buccally, and the whole body of tissue is left untouched. And now you have the opportunity to see tissue growing. And now look, where is the premolar implant-supported crown at the level of the premolar compared to the adjacent tooth? Even shortened. And if you look at the situation before and after, and if you place the crown in the situation of the tissue before, you can see that it's almost incredibly, because the crown is 1 millimeter more coronal at the level of the buccal aspect, and the papilla is completely filling an area that was completely empty before the surgical procedure. So in one surgical procedure, you can promote papilla growth. Transmucosal implant is highly recommended because the abutment connection is far away from the bone crest, and so the biological width can form with no further bone loss on the suprabony component of the implant. But look at the emergence profile. Remember the concavity that was present before, and this for sure is the most impressive, because you can see that not only the buccal soft tissue was increased in thickness and in height, but now we have two papilla that is almost identical to the papilla of the adjacent teeth that has intact bone peaks. And this obviously was done with no change of the bone level, because I did not make anything to increase the bone, but I did everything to do what? Increase the thickness. Look at the papilla thickness 5 years after the surgery compared to the dimension, buccal lingual dimension of the papilla. So now we know that the most predictable way to achieve papilla growth in apicocorno dimension is to increase the buccal lingual dimension. And how can you increase the buccal lingual dimension of the papilla? You have to extend the connective tissue graft to this area. But if you don't elevate the papilla, dear friend of mine, you will never experience papilla growth. You will never experience reduction of the implant-supported crown when you start in a situation in which some shrinkage of the tissue really has to be compensated only by soft tissue augmentation procedure. The bone doesn't mean absolutely nothing. The bone, it's something that starts more apically. And when you see the occlusal aspect, the tooth that still have the root and the buccal bone, or the tooth implant supported, they don't have anymore the root and the buccal bone, there is no so much difference at all. So we can say that for sure, from aesthetic point of view and also from a maintenance point of view, the absence of the root of the adjacent tooth and the absence of the buccal bone can be easily compensated with soft tissue segmentation procedure in one surgical time. So most probably we are getting to the opposite of the previous conclusion. Yes, some amount of bone loss can be easily compensated by soft tissue augmentation procedure, while it's absolutely not true that by augmenting the bone, you can augment the papilla height or the soft tissue height, because this is an area that don't belongs to the bone ever. This is the 7 years. Just to give you the long-term stability, you see that the implant-supported crown is even shortened with the papilla completely filling the interproximal space. This is the emergence profile of the implant-supported crown, while some minor recession occurred in the two adjacent teeth, canine and premolar. The implant-supported crown is the only tissue that is still stable. Why? Because the tissue here was not increasing the thickness, and most probably the patient has lost some quality of attachment, while here the thickness is so good that you will never experience, for sure, gingival recession because of the increase in the soft tissue thickness. And this is the long-term stability of the bone, also in the radiograft.